Hello, my name is Martin Lipscomb, and I'm talking to Dr. Charles Djordjevic of Lorain County Community College and the Cleveland Clinic Foundation about his recent paper, Pain Cannot Just Be Whatever the Person Says, a Critique of a Dogma. In this work, Dr. Djordjevic, who speaks to his own views and not those of Lorain County or the Cleveland Clinic, argues against uncritical acceptance of Margo McCaffery's famous and influential assertion that pain is whatever the experiencing person says it is, existing whenever he or she says it does. Now, questioning and indeed refusing McCaffery's claims about pain will, for some nurses, seem provocative. However, Charles is persuasive in his writing. He presents interesting arguments, and pain is clearly a topic that all healthcare workers need to consider. Charles, thank you for agreeing to talk about your paper. Please, can you outline the position advanced in the work? What is the problem with McCaffery's definition of pain? How instead should we think about pain?
Certainly. And first off, thank you for interviewing me and the reception of my paper. I agree it can be controversial, but hopefully it will start some thinking. So the best way to start thinking about McCaffery is we need to consider the context in which she was writing, and then I'm going to start to talk about why I think in many ways she sort of overextended certain lessons she learned. So McCaffery was an oncology nurse, right? And one thing we've learned is that one of her preferred treatments for pain, which was opioids, work incredibly well, fortunately for everyone, for cancer pain. That's very well borne out in the literature. Problem is, for non-cancer chronic pain, it's mixed at best. And it gets worse, especially in the US context with what's going on with opioids right now. I mean, that's a whole long and terrible conversation. So that's part of both her context and the reason why I felt it necessary to reply to her, right? She sort of took lessons that she rightly learned from her patients with cancer and extended them to the entire population. So best way in for McCaffery is we should go back to her original definition. So she tells us that we need to think about pain as whatever the experiencing person says it is, existing wherever and whenever the person says it does, right? That's her basic definition. And a way into the worry I have is to replace the word pain with a made-up word, because I think that shows the limits of this account. So let's say someone shows up to a hospital and they start saying, I have a shmoo, please help me. The shmoo is really bad. It's really upsetting me. I can't stand it anymore. Well, the question is clearly something's wrong with this person, right? Clearly they don't go to a hospital and start complaining and insisting that we treat their shmoo. And yet it's not clear that I, as a provider, or anyone as a provider, has any sort of way of knowing what this is, what a shmoo is supposed to be. So if we say a shmoo is whatever an existing person says it is, existing whenever and wherever it does, it gets even worse, right? Because I just don't have any into that anymore. I can't see what's going on there. So it seems like, based on that, we have two ways to go, right? One of them is we do what we typically do in healthcare, right? I get an EKG, I work as a cardiac nurse, so I get an EKG, I do an echocardiogram, things like this. I try to look at the underlying sort of physiological changes afoot. I get a blood pressure, I take the vital signs. And McCaffery rightly is really worried about this because pain doesn't always correlate with those things, right? So she's going to say that's dead on the outset, right? We can't take what's going on with someone's blood pressure or their respiratory rate or whatever as an indication of pain, right? Pain doesn't meet any of that. So that's out. So the question is, well, how am I going to figure out what this shmoo is? How do I know what's going on? And what she seems to want to suggest is that we need to go to something like neurology, right? We need to start looking and seeing if there are certain features of the brain that maybe show up on an MRI or wherever that correlate. So every time I have a shmoo, I have these brain correlations, these neuropathophysio-neuropatho-physiological states that sort of underlie it, right? So that's the way she wants to go. And what's interesting is that she knows that neurologically speaking, this doesn't quite work, right? Pain seems to manifest itself in all sorts of different correlates in the brain. So what she gives you is sort of a promissory note. She says, well, look, pain science is very new. We'll get there. For now, let's just assume that, it's just we still haven't quite figured this out. And that's fair. I mean, the brain's unbelievably complicated. So let's take this at her word. Let's assume that maybe in whatever 30 years, neuroscience will be at the point where we can actually see what a shmoo is on an MRI scan. This, I think, raises, even granting her that, and we'll come back to why I think even that's granting her too much, but that raises three real problems for her account, right? And part of the paper is showing why that attempt to look at objective correlates, which is part of how she wants to try to get into pain, or shmoo in this case, come apart with her insistence on patient subjectivity, right? So the first worry is actually ethical, right? And so McCaffery rightly, and I should stress this, I respect her deeply because of this, was rightly horrified by the failure of healthcare to address pain ethically, humanely, right? When you read her, and I mean, it's an interesting question how right she was about this, but you get the sense that up until a certain point in the late 1950s, early 1960s, providers simply didn't care about pain, or they took it as a secondary and negligible matter. And she rightly says, look, the reason people go to a hospital is often because of pain, and it's inhuman for us to just ignore this as something that, look, I care about the fact your blood pressure is 210 over 150, right? I don't care about your pain. That's just not okay. The worry with her way of thinking about pain or shmoos in terms of brain states is that it removes all context, right? So by assumption, every time I have a shmoo, I have the same brain state. But what's weird about pain is it seems like context is going to matter enormously, right? And this is on all sorts of fronts, right? So the pain, and the literature here is very interesting. The pain that people experience when they're giving birth seems to be very different and demand a different sort of treatment than the pain from someone who's had a horrible car accident, or the pain from someone who just doesn't know why they're having pain. All of these seem to demand different sort of ethical responses. And McCarthy just levels that. What matters is the brain state. I treat the brain state and that should fix the pain. And it's very easy to construct examples where that goes horribly wrong for healthcare providers and for the patient. Someone who comes into the patient after having the terrible misfortune of experiencing, say, domestic violence. Yeah, okay, there's a physical aspect to that, and it's good to try to treat that, but there's also this psychological and social feature that's just going to be eliminated or suspended by thinking about it in terms of brain states. So that's the ethical worry. The second worry has to do, and already we start to see how objectivity and subjectivity start sort of coming apart. So McCaffery tells you, and just realistically, this happens, right? You tell a patient, rate your pain, rate your shmoo on a scale of 0 to 10, and they give you an answer like 15. And so McCaffery has to have an answer to that. And so she says, well, look, they've sort of misunderstood how the rating scale works. It's the job of the nurse to educate them. You can't have a pain of 15 over 10. The problem is I don't know what basis she possibly has for wanting to say something like that. And this comes out really clearly if we cross out pain and put in the word shmoo, right? So I decide arbitrarily as a nurse, as a healthcare provider, that a shmoo can only be 0 to 10, that a shmoo can be burning or stabbing or aching, but it can't be tasty or blue. And then I start forcing the patient to accept this way of thinking. It's very easy to see how this becomes really, really deeply problematic for her, right? So if a shmoo or a pain is whatever I say it is, and I say a shmoo is blue and tasty and 15 out of 10, by definition, that's what it has to be, right? So it's not at all clear what she means by educating a patient, right? And it goes even a level deeper than that, right? So the assumption is that somehow someone telling me my shmoo is 7 out of 10 gives me some bit of information. It can let me, better assess them, can guide my treatment. And you see it clearly when we replace pain with a nonsense word that I just define as whatever I experience. That doesn't work, right? Telling you my shmoo is 7 out of 10 gives you no deep understanding of what's going on with me, of how you should address me, of how you should treat this. There's nothing there. And so in this key, she's playing off of intuitions about what we expect about pain that I don't think she can rightly assume, right? If we take the letter of her definition seriously, pain's whatever I say it is, I have no reason to assume I know what a 7 is, right? And then even the third worry, so you have the ethical worry that she's basically suspending context and just trying to look at brain states, and that's going to cause problems. You have this educational worry with pain scales and trying to even begin to understand. The third worry is that she says at several points that I can misunderstand or misperceive my pain, right? So her examples from this come from pediatrics, and she's on good ground there. I mean, it seems like evidence suggests that especially younger children often confuse their pain with things like anxiety, or even she wants to go so far as to say that someone sleeping can still be experiencing pain, right? So I cannot perceive my pain, I can misperceive my pain. But then the problem is, what role does this brain state, does this underlying thing have, right? So if my experience of pain is what makes it what it is, and yet I can be wrong about pain, you've torn these two things apart completely, right? So obviously, for me to have an experience of pain, it seems like, and McCaffery says as much, I need to be aware of the pain, I need to know about the pain. And yet she's committed equally well to the fact that if my brain is doing certain things, I'm in pain, whether or not I admit it or perceive it or whatever. And so this gets really, really weird. So there are two different moves she can make, and I think at this stage, and I don't think either of them get her anywhere. I think they make everything worse. So one of them is to bite the bullet and to just say, look, what really ends up defining pain or a shmoo is the underlying neurology, right? It is the brain state. My perception of it is sort of accidental. It's the best evidence I have at the moment, but when the science of pain makes more progress, we'll have much more reliable diagnostic tests. The problem with this is simply that seems just wrong. If I say I have a pain and they do a brain scan and it turns out the correlates that she thinks we'll eventually discover aren't there, it's not going to help that person to say, no, you don't really have a pain, right? I did the brain scan, it's not there. That's not treating them as a person. That's not helping them with their pain. If anything, that returns to the model she's trying to get away from, right? The symptomology of pain is irrelevant. We have the neuroscience now. You think you're in pain, but you're not. that's the end of it. And that's not where she wants to go. The other move she can make is to drop this business about neurology completely. But the problem with that is then we're stuck with the original difficulty, or I would go so far as to call it an incoherence with her way of thinking about pain, which is pain's whatever I say it is. If it's whatever I say it is, existing however I want it to exist or however I think it exists, you have no grounds for assuming that you understand it. And because you don't have any grounds for that, you have no guidance in how to treat it, how to diagnose it, how to even begin to deal with it. Again, the idea of someone coming to a hospital and saying, I have a shmoo, and then being told, well, whatever this person says is a shmoo is a shmoo. There are no objective tests for shmoos. So, whatever they think you should do for them is what you should do for them. I mean, that's kind of not helpful, to put it very mildly. I mean, imagine, to play with an example she gives about insulin in one of her papers, imagine someone says, I have a shmoo, I need 7 units of insulin. Well, that should make you really worried, right? You're going to want to check what their glucose is before you give them 7 units, or you're going to cause all sorts of problems. And it's utterly weird that in this context, we know that, and yet McCaffery seems forced into this position where someone shows up, they say they have a shmoo, they demand, 10 milligrams of oxycodone to deal with the shmoo, and the provider's simply supposed to give them the oxycodone. I mean, not only does this seem really conceptually problematic, it's sadly empirically the case that this leads to all sorts of really problematic pathologies, right? Pathologies ranging from, again, in the US context, the opioid crisis, to even damaging, and this is the point where I think we begin to see a different way of going on, damaging the clinician patient relationship, right? The patient's demanding this of you as a provider. You don't understand it. You don't understand why they think this will help. And you're told that you should just take it on blind faith. And obviously, as a responsible clinician, you're not going to just take it on blind faith. And then this weird tension emerges, right? So then the question becomes, okay, so what do we do, right? McCaffery's right that we don't have any reliable, physiological indicators for pain. I would go further. I'd say we have no reliable brain states that correlate with pain. And yet we can't let this just be whatever the person says it is, because then we have no ground to even begin to deal with it. And so my proposal in the paper, and I don't develop it as much as I'd like, I'm hoping to work on that later, is that we go to a different school of nursing that I think is on much firmer feet, which comes out of Dame Saunders and the hospice movement, right? So what she wants to do is say, look, for us to understand pain, it's not enough for us to look at, changes in blood pressure, brain states. You need to look at how this word sort of entwines with the entire way this person is trying to live their life, right? So what she realizes, so go back to the person who comes to the hospital and says, shmoo, I have a shmoo, the shmoo's really bad, I need treatment for it. What Saunders says is, yeah, okay, maybe that's not going to nicely correlate with blood pressure. But if you watch the way this person's trying to engage with the world, try to act and interact with themselves, with their friends, with you, you're going to start seeing patterns, right? And these patterns are going to be deeply, deeply embedded in this way the person has been living, in their understanding of themselves, in their entire social world. And Saunders, I think, is right. She says not only this social world, but even their spiritual world. What do they think the value of their life is? How are they trying to reflect that? How is this moment of terror stopping them or problematizing that? And Saunders says basically, we need all of that information, right? It's not enough for us to try to look at data points, right? You need to look at the whole pattern of the data spread across their lives. And what she realizes, and to the very real credit of hospice, it takes months to really properly do this. You know, I mean, her idea of total pain is born out of the realization that really understanding what, you know, someone who's dying of cancer and who's estranged from his son and, you know, has all of these social problems and regrets and just feels like they haven't lived a meaningful, good, flourishing life, you know, really getting clear on that and really helping them to deal with that requires exactly what I think the nursing practice rightly centers, which is this patient-client relationship, this really holistic view of this person, not as a data point, not as neurophysiological correlates, not as blood pressure, but as a human being who's facing struggles, right? And so in some ways, what I think Saunders started to do, and this is part of what I'm starting to work on now, is she changed what pain's about, right? So in McCaffery, pain's about this subjective state. Before McCaffery, arguably, pain was about tissue damage or these correlates or reductive neuroscience. McCaffery says, or excuse me, Saunders says, look, McCaffery's right to get rid of these objectifying correlates. It's not about a subjective state, right? That can't be all it's about. It's about this entire way it entwines with a person's life. And the last point I make in the paper is that my own understanding of what it means for me to be in pain actually tacks onto that, right? I understand a painful sensation not just based on some weird subjective moment in my head. I look at how it affects me, how it affects what I'm trying to do, how it problematizes my relationship. And so even from a first person perspective, it seems like the way I myself make sense of what's going on in me is by pairing it with how it's you know, limiting or affecting or reducing my functionality, my ability to be in the world in the way that I would like to be. You know, the fact that I can't put on pants anymore because my leg hurts so badly. That's a core part of pain. And I think Saunders is right to say we need to stop trying to reduce pain to anything, be that tissue damage, be that subjectivity, be that whatever. And we need to look at the person as a whole and their entire range of engagements, from everything from, you know, they can't walk as well, to they can't laugh with their friends, to they no longer find their life meaningful. All of that's going to be part of pain. And that's what Saunders means by total pain. And so I end the paper by suggesting that the best way for nursing to move forward with pain is to agree with McCaffery both that it's ethically outrageous that we're doing such a bad job at handling it, but to reject her subjectivization of it, this attempt to peg it to some weird feeling or sensation or whatever I have in my head, and to start trying to look at the whole form of life, to totalize pain, to borrow Saunders's language. So that was the basic thrust of the paper, and that sort of reflects the structure of how I went through it.
Okay, that's very, very interesting. Thank you. Of course, Dame Cicely Saunders was coming from a particular perspective. She had a particular patient group that she was looking after, and some people might find some of her reasoning problematic for a variety of reasons. But your paper is a really interesting paper. I'm persuaded by what you say, but just let me ask, and I think this does pick up on what you've been saying, how realistic are your proposals? For example, you suggest pain assessment requires, and here I quote, a form of watchful waiting, a form of deliberate attention that helps both the provider and the patient understand what is needed, end of quote. Okay. But given the frenetic busyness of current healthcare environments, and of course, nurses will be dealing with people who aren't necessarily at the end of their life or whatever, is this feasible? It might be desirable, I assume it is. However, have nurses time to engage in the kinds of thoughtful and extended encounters with patients that the phrase watchful waiting implies? I think you recognize this in your writing. Nonetheless, can you say a little bit more here?
Sure. So, and it's a very, very good question. And so I would preface it by making one point, then I'll make a practical point and sort of a theoretical point as a reply. So my preface is it's going to depend on how seriously we take pain as a vital part of healthcare, right? You're absolutely right. I mean, I myself have around 5 patients every day. And so this sort of method of engaging with them, even something much less sort of holistic and time intensive than what Saunders is up to, it is going to require a change in how I'm allocating resources, right? It might require me to have a smaller patient load. So flowing from that, the theoretical question, or perhaps the ethical question to ask, is how seriously are we about treating pain, right? Because it seems like if we are really serious that this is a chronic problem that many people suffer from needlessly, then yeah, maybe we need to rethink patient loads. Maybe it would be better if nurses had only 3 patients so they could do this in a little bit more of a watchful waiting in an engaged way. That said, of course, that's going to run into the problem of the nursing shortage, which is sadly very worldwide, and all this. The practical solution, which is more sort of in keeping with how healthcare is as opposed to how I would like it to be, if you like, is there's really interesting work right now being done. It was put forward by the US Army Surgeon General. They created a new pain scale that's called like the Defensive Veterans Pain Scale, something like this. And what this does is that it incorporates systematically and relatively quickly elements of what we've just been discussing. So instead of just having a patient rate their subjective state, it also, so that's one dimension. It also looks at their functionality, right? And it has both the provider and the patient sort of look at how this is entwining with their form of life. The nice thing about it is it's slightly more time intensive, but not much, right? So it's sort of as you're interacting with your patient, as you're watching them move around, watching them do their things, it gives you a very nice set of specific criteria that say, how are they walking? Can they eat by themselves? Very simple things you can assess pretty quickly. And this seems to be a step in the right direction, a step towards sort of putting another dimension into pain instead of just, the numeric pain scale on a scale of 0 to 10, how do you subjectively rate your pain? And the nice thing is the research is still forthcoming, but the last paper I looked at from 2017 is that not only is this relatively easy to implement, I mean, you have to update whatever computer software you use to include this functional dimension. Patients and providers both prefer it at a fairly high statistical rate. And I think that incorporating that data, even if it is not quite where I would like it to be, is a practical solution to start to understand, and by understanding, deal with pain in a more fruitful, systematic, and humane way than the standard pain scales are, right? So that would be my practical point, is that if we can't, for various practical reasons, can't reduce patient load for nurses, which sadly I don't think we can right now, we can at least extend or expand the data set we're looking at. And we can do that in a very rigorous, systematic way, that, yeah, maybe it takes another minute or two, but you can make that work, especially, again, if we're serious about trying to treat pain humanely. So those would be, the ideal world would be we reduce patient load. In the real world, or in the world as we have it, it would be including more data. That would be my way forward here.
Okay. Charles, that was really interesting. I recommend your paper to everyone. Thank you for making time to talk to me. And for those who do want to read further, links to Dr. Djordjevic's work and the paper in question are located in the notes. Charles, thank you once again. Thank you for joining me.
Thank you for having me. I'm very grateful. And yeah, thank you very much.
Cool.